'Cause all of me loves all you. Love your curves and all your edges, all your perfect imperfections. Give your all to me, I'll give my all to you. You're my end and my beginning. Even when I lose, I'm winning. 'Cause I give you all of me, and you give me all you. Oh. 'Cause
Halo Mbak Devi.
Halo, ya, terima kasih.
Ya,
Cantik sekali hari ini. Ya, silahkan, nggak apa-apa. Ini sudah jam 14.54, silahkan dimulai. Kita announce dulu sama Prof. Ewa, minta izin dulu untuk dimulai.
Oke. Beliau udah di sini Mbak ya. Suaraku jelas Mbak?
Jelas, jelas sekali.
Oke. Kenapa Mbak?
Jelas sekali.
Oh ya. Oke, kita mulai ya. Mulai Mbak? Mulai? Oke.
Silakan.
Okay, good afternoon everyone. Welcome to our webinar today. Thank you for joining us. My name is Rizkia Khuluki. I'm your host today. I'm part of Physiokita member. Physiokita is a platform for physiotherapists that bring evidence into practice. You can check our feed in our social media, such as Instagram, Facebook, and then there's a blog also called Physiokita. Okay, anyway, today we are presenting GLA for osteoarthritis, presented by Professor Ewa Roos, PT, PhD. Maybe for some of you already know her, but let me introduce her first. As we know, Professor Ewa Roos is Professor of Physiotherapy and Head of Research Unit for MSK Function and Physiotherapy at the University of Southern Denmark. She is also the creator of the GLAD, which is Good Life with Osteoarthritis Denmark. GLAD is a neuromuscular exercise for patient education delivered in primary care to osteoarthritis that has been shown to increase function and decrease disability. In 2014, she received the Osteoarthritis Research Society International, ORSI, Clinical Research Award. She was also awarded to the Queen Ingrid of Denmark Prize for Outstanding Arthritis Research by Queen Margaret II, and the Danish Rheumatism Association. So it's our pleasure to have her here, and we hope someday we can meet face-to-face with her. Maybe she can teach here in Indonesia. Is that right, Miss Professor Roos?
I would hope so.
Oh, that would be lovely. Okay.
Yes, I think so too.
Okay,
it would be great to meet international people again after being in your own region, in your own country for a long time now.
Have you been here before?
I've been to one of your beautiful islands.
Oh, I see. It's Bali, maybe.
Yes.
Okay.
On my way to Australia. Yeah.
Oh, all right. Okay, before we started, if you guys have any question, you can type in your Zoom control panel. There's a chat. You can type that, and after Professor Roos finished the presentation, we will do Q&A season.
Yeah.
Okay,
That
Professor
sounds
Ewa
good.
Roos, I think it's time is yours.
Thank you.
Maybe you can start.
So good afternoon, everyone in Indonesia. It's good to see young and a little bit older physiotherapists and maybe physiotherapists to be. I am in Sweden. As you've heard, I'm a professor of physical therapy and of musculoskeletal function. And I work mainly with osteoarthritis and with sports medicine. So I have been asked to talk about GLAD, which is Good Life with Osteoarthritis from Denmark, and how it works for treatment of patients with hip and knee osteoarthritis. And I will take you through the journey, how it started with GLAD, and a little bit about the results. And if you have questions, please write them in the chat and I will address them afterwards. So first of all, one thing I really would like to say is that when we started GLAD, I did that together with my colleague, Professor Søren Skov. And we were the team, and without him, it would never have been a GLAD. So I really would like to acknowledge his contribution to establishing GLAD. Let's see if I can make this work. So I have no financial disclosures, which is an important thing to say in this. I have developed many patient-reported outcomes measures, and they are freely available. And I am the co-developer of GLAD, but GLAD is a not-for-profit initiative. So that means that, and it's owned by our university. And by law, universities cannot make money. So that's why it is a not-for-profit initiative. So the money that we will make from courses, we use that to run the register and to improve the concept and to help other countries get started. I'm also the deputy editor of Osteoarthritis and Cartilage. So what is GLAD really all about?
Det her det er jo et rigtig fint tilbud for patienterne. Det har vi efterlyst mange år i praksis. Det er sådan, at det er en meget stor patientgruppe, og vi er nu glade for, at fysioterapeuter nu kan tilbyde dem en behandling, som har effekt inden for det her område. Det har vi manglet.
Der er ikke nogen tvivl om, at GLAD har højnet niveauet i praksis, og det har gjort, at vi er sikre på, at vi lever op til de kliniske retningslinjer.
Sådan som jeg føler, så er det ligesom om, jeg har fået mig et helt nyt liv. Og jeg føler mig overbevist om, at jeg ikke skal have et nyt knæ, og det var jeg ellers bange for.
So now you know what GLAD is about. So maybe I should stop the lecture here, but if you would like to hear more about it and the way we put it in context, please hang on. So when it comes to osteoarthritis, clinical guidelines all around the world actually agree the way we should treat them. So we usually call the approach the osteoarthritis treatment pyramid. And you start in the bottom in the green part. So everyone that seek medical care because of joint pain or functional limitations, they should be offered first-line treatment. And first-line treatment is defined as patient education, exercise, and if you're overweight, it's also about weight control. That is the first-line treatment. And for many people, that is sufficient to give them the pain relief and the functional improvement that they need. If it's not enough, you can add on pharmacological pain relief, aids like a walking stick, a Nordic like poles for pole walking, And it could be passive treatments given by a therapist. And passive treatments, that could be, for example, mobilization or manipulation if you have a decreased range of motion of the joint. So that is up to the clinician to decide and individualize for each patient what is required. But please note that it is an add-on, because the green part, as you can see on the pyramid along the side, continues. So you combine these two efforts. And when they have been exhausted and the patients still have a substantial pain and problem and they cannot live the life they want, then they should be referred to a surgeon to see if surgery is something that can help improve their condition. And the type of surgery that is beneficial for these patients, that is to having the joint replaced. But we usually would say that it should be done for later stages of osteoarthritis, when you've had your problems for a long time and when you have exhausted all these options. And as you can see on the right side, it says all, some, and few. And it has been estimated that it's about maybe 15% of those who see a general practitioner who actually have problems that are severe enough to have the surgery. So those who require the surgery is a very small proportion of all those we see in primary care with osteoarthritis. That is also important to know. I grew up at the Department of Orthopedics, and if you talk to an orthopedic surgeon, they usually will say that osteoarthritis is not that much of a problem because you can just replace the joint. Well, there may be some problems with that, but anyhow, what you see at Department of Surgery is actually only a small proportion of all the patients with osteoarthritis. That is important to remember. So we've known this for many, many, many years, that this is the way we should treat osteoarthritis. But it hasn't happened. It hasn't changed clinical practice. And I'm in the position that I've been working as a clinician for more than 15 years, but that was back in the last century. I'm also in the position that I give lectures, just as I give a lecture for you now, for clinicians. So I kind of understand the clinician's position, and I understand the researcher's position. I'm also lucky enough to have been sitting on clinical guideline committees in many countries, in Scandinavian countries, in China, worldwide, about osteoarthritis. So I've actually been through all the literature that are underpinning the clinical guidelines. And I can see why this is so difficult, because it's not easy for clinicians to read clinical guidelines and to understand how to do it in clinical practice. So for many years, we were talking to healthcare authorities about bringing the research evidence out in clinical practice. But there were many barriers, and they were usually centered around politics, organization, and financial incentives. All aspects that had nothing to do with research evidence. And as a researcher, you felt like there was really nothing you could do because there were all these barriers to changing how we deliver treatment for people with osteoarthritis in clinical practice. So there is really a gap between research evidence and osteoarthritis treatment guidelines and what happens in clinical practice. Because we've known for many, many years that exercise is really good medicine for people with osteoarthritis. And it is in the clinical treatment guidelines all over the world, but too little happen in clinical practice. So we actually decided to try to bridge this gap, and that is what GLAD is all about. But how? How to do that? Well, if you read the big book about implementation, it's usually top-down approaches, and that starts with the big pictures, and you discuss with the healthcare system, and then it breaks down from there into smaller segments. Well, we had tried that for many years, and although the healthcare authorities thought it was a really good idea to implement clinical guidelines, there were all these barriers that related to politics, organization, and financial incentives. So we decided to do it the other way up, bottom up, and to engage clinicians, give courses to clinicians, and ask the clinicians to help spread the word to patients. So when we started GLAD, we had a strategic plan, and it was to inform about GLAD in daily newspapers, professional magazines. We wrote up scientific publications on the results from a pilot study. We submitted abstracts about GLAD to Danish conferences in orthopedics, rheumatology, physiotherapy, etc. And we set up courses for physical therapists to get GLAD certified to deliver the program. And we explored the ethics, possibilities, and pitfalls regarding electronic databases, so we could make the GLAD registry into a national quality register. And we also met with politicians on national and local level. So we did a lot of things except addressing the healthcare authorities. We also got very busy in talking to journalists. That was really, really helpful. And we even got it on the news, on the TV, where they said it was breaking news. And we found that quite embarrassing because we've known for 20 years that exercise is good treatment for osteoarthritis. But once it was on TV, patients started to ask their general practitioners for this treatment, and the ball started to roll. We were lucky enough to get the Minister of Health, Astrid Krag, the woman here, to come and visit one of the sites and do the exercises. And she had really good quad strength. So that was a good experience. So GLAD has 3 components. We ask clinicians to come to our university and to take a 2-day course to become GLAD certified. These clinicians then go home to their own clinics. That could be private clinics, or it could be in public, and they offer the program to their patients. Clinicians and patients also submit data to the GLAD registry, and we then summarize this data into an annual report that we feed back to clinicians and patients and politicians and whoever would like to see the results of this treatment. And I would say collecting data has been key for GLAD's success. So we have the 2-day course, we have the treatment, and the treatment consists of patient education and of exercise therapy, and we have the data collection. And all these 3 parts are mandatory of the GLAD. That makes GLAD different from many other treatments that physiotherapists deliver, because I'm sure that you have been to many courses where you learn about something, a technique or whatever, you go home and deliver it in the clinic, but you never collect the data to look at the outcome of your patients. That is what makes GLAD different. And that is also why GLAD is such a success. So during the 2-day course for clinicians, the clinicians, they learn about osteoarthritis. And they learn about osteoarthritis in an easy language that they can use during the patient education. They also learn to deliver a standardized, structured, and progressed neuromuscular exercise program. We have chosen to deliver a neuromuscular exercise program. That is not to say that aerobic exercise and strength training is not good for people with osteoarthritis, because it is. But there are reasons why we think it is better to start with a neuromuscular exercise program. And we do that because it focuses on the joint. It uses the pain as a tool for progressing the program. And it also addresses the lack of trust that many people with osteoarthritis have in their joints and in their legs. They don't really dare to do things because they don't trust their legs. So those are the aspects that we actually address first. And hopefully after the program, they can go on and do other types of exercise that, or work or whatever it is that they enjoy doing. And we also do it because NEMEX is, the neuromuscular exercise program is feasible. We have tested that many times and it's safe. And it's safe even in those with severe osteoarthritis that are waitlisted to have their joints replaced. And we have over the years applied it in the clinics in more than 50,000 patients by now, and in many research studies. So we have good evidence for this type of treatment. But just remember, it's not the only type of treatment, but it's a treatment that we have found it very beneficial to start with for people who have osteoarthritis. So it is good for patients who have osteoarthritis because it targets the OA joint, and it is meaningful to patients and clinicians. Because if you would have a patient to come into a clinic to sit on a bike and bike for 20 minutes, they may wonder, why should I do that? Because they could bike anywhere or have strength training. You can go to a gym and do that. But for neuromuscular exercise, you need feedback from a skilled physiotherapist to get a good movement quality. And you need, very often you need a physiotherapist to hold your hand because you exercise with pain, and that is scary to a lot of patients. So neuromuscular exercise is different from strength training, where the goal is to improve muscle strength. And it is different from aerobic conditioning, where the goal is to improve the cardiovascular output. We have decided to use only inexpensive equipment because we don't want cost to be a barrier for physiotherapists to start this program. And we don't want the cost to be a barrier for patients who would like to continue the programs once they have finished with their physiotherapist. So people with osteoarthritis, they are different from other patients who get lifestyle advice to start exercising. So if you take people with diabetes or cardiovascular disease, they will also get advice to lose weight and to start exercising and become physically active. But people with osteoarthritis, they're different because they have painful joints and they are afraid of hurting the joint. And they often have a fear of exercise for that very reason. And that is one reason why it is very important to give these people feedback and to hold their hand when they start exercising, because they often need that to continue to exercise. So we use a pain monitoring scale during the program for progression and regression. And it's 2 simple pain rules. So we would say that, let's say that we have a patient coming in the clinic and their normal morning pain is 2 or 3 on a scale from 0 to 10. Then we would say that when they exercise, they can have up to 5 on the pain scale, which is acceptable pain. But the morning after, the pain should be back at their normal level, which is then 2 or 3. Then they have not done too much. But if the pain after exercise is over 5, or if it doesn't go down until the next day, then they have done too much. Then it's your job as a physiotherapist to adapt the program to make it easier for the patient. So this is how we work with progression and regression. And we can tell our patients that it is okay to exercise with pain. It's actually normal, because if you haven't done anything for a long time, this is your body's way of telling you that you're doing something you're not used to. So what you can see on this slide here is that you can see on the y-axis, you can see joint pain. So this is a group of patients who have been exercising, and on average, their joint pain increase with maybe 10% or 0.7 on a 0 to 10 numeric rating scale for pain after the first exercise session. So that is a pain flare. And after the second session, they got a little bit smaller pain flare, and the third even smaller. And you can see that the size of the pain flare goes down with the number of sessions that you participate in. So it is normal and okay to exercise with pain, and it will go away when you continue to exercise. So we actually have the patients record their pain in an exercise diary. We also have them record their progression in an exercise diary. And many of the patients, they can actually see that they can do more things. They can progress their exercises with the same pain, or eventually they will also see that their pain goes down and they can do more. And this is a very good feedback that empowers patients. So patients and physiotherapists, they enter data into the GLAD registry. And they do that at baseline before the program starts. They do it at 3 months, and they do it at 12 months. And the type of data that is entered into the registry is patient descriptives. That is data about the patient, you know, age, sex, BMI, other things like that, for how long they've had their problems, etc. And we also have self-reported data. That will be measures of pain and physical function, self-efficacy, other things. And we also do objective tests. So we test the walking speed and we test the chair stand ability. And we have chosen these tests to have as little, you should be able to do them as quickly as possible as a physiotherapist, because we don't want this program to take up more time in your busy clinic. And it actually works very well. So what we then do is that we collect this data and we summarize it in an annual report. But before we continue, I think it is time to have a little pause here, because I think that your cartilage really needs some nourishing now, because you've been sitting for a while. You've been sitting for 20 minutes, and that is about when you need to stand up to give your cartilage a break. So I would like to test you and see how many chair stands you can do in 30 seconds. So you do the job and I will do the counting.
All right.
So I have my timer here now. And I'll put it on 30 seconds. And you know what to do. You fold your arms over your chest and you stand up all the way up, and then you sit down all the way down again. Please try it once so you know what to do, and make sure that if you have a chair with wheels on, be careful so you don't hurt yourself. So please stand up, all of you, and sit down again.
Oke, jadi buat yang peserta, kita mau nyobain yang ada di gambar. Jadi semuanya silakan berdiri di, kalau ada kursi silakan berdiri di atas kursi, duduk di atas kursi. Kemudian sesuai nanti timernya dihitung sama Professor Roos. Kita melakukan seperti di gambar selama 30 detik. Nanti kita bisa berapa kali. Ready ya semuanya? Oke, Prof.
Are you ready?
Yes.
Because now I will count for 30 seconds.
All right.
So ready, steady, go. Start moving. Stand up, sit down. All of you. Your cartilage needs this, you know. Stand up, sit down again. Come on, you can do better than this. Stand up, sit down. That's going really well, really well. Good job. 10 seconds to go. 30 seconds is quite long, isn't it?
Yes, it is.
Yes, it is. stop.
All right.
Oops. I'm trying to stop it. Stop it. So how many could you do? Let me know how many you could do.
I'm 14. So only 14.
14.
What about the anyone? 21.
20.
20.
20.
Good. Anyone who did more than 30?
14, 15, 21, 18, 21 again, 14 again,
Okay.
24.
So now you can compare yourselves to patients in Denmark with osteoarthritis. So you can see that on average, people with osteoarthritis in Denmark who are 63 years on average, they do 12 chair stands in 30 seconds. If you do less than 10, we know that you have an increased risk of falling. And if you do more than 30, you're really fit and you do more than all the patients with osteoarthritis in Denmark. So on average, an osteoarthritis patient in Denmark do 12 chair stands. And when they have been in the program for 6 weeks, on average, they can do 2.2 more chair stands. And that is really good because that will help them to get up from a chair, to sit down in a chair again, which is a very good part of activities of daily living, which is something that we do quite regularly. Okay, so I hope that your knees feel better now when you've been stretching them for a bit. And this is data from the GLA registry that I'm showing you here. So who is it really that is included, or who are included in the GLA database? Well, one should know it is a unique database of patients with knee and hip osteoarthritis that are treated in primary care. And that is unique in the sense that there is quite some data available from people with osteoarthritis who have their joints replaced in registries. So we know quite a bit about these people, but there's very little data available on patients treated in primary care. So I will show you some of our results from Denmark, but you need to be aware of the strengths and the limitations of this data. A strength is that it is a well-defined cohort and they very well represent the type of patients that you see as a physiotherapist. But of course, this database only includes those that are treated with patient education and exercise therapy by GLA clinicians. So it is patients who want to do this program. And you should also know that the large majority pay at least partly for their treatment in Denmark. And surprisingly in Denmark, that might be surprisingly to you, visits to the general practitioner and having surgery are free, but you have to pay to go and see the physio. So we started GLAD in 2013, but GLAD is now all over Denmark. And as you can see, we normally have about 10,000 new patients into the register every year. And there are about 350 active GLAD units in Denmark. And active means that these clinics send in data to the registry. And this is a map of Denmark. Denmark is not a very big country, but you can see that if you, for example, live in the capital, which is Copenhagen, there are 64 clinics, and this works like a Google map. So if you click on it, you will see all the clinics and all their addresses. And you can actually also enter your address and search for clinics that are close to where you live. So as you can see, there are clinics all over Denmark and even in the islands. So who is it then that participated in GLAD? Well, the mean age or the typical patient is a 65-year-old overweight woman with knee pain. And as you can see, there are very few patients that are between 30 and 50, but they are there. And commonly, this would be patients who've had a major knee injury, maybe as a teenager, a sports injury, and who develop osteoarthritis early in life. It could also be patients who were born with hip dysplasia or had a hip disease early in life and who developed the disease earlier. We also have patients who are over 80. And I know in GLAD Canada, they have had a patient who was 100 years old. So you can do this program when you are at very different ages. You can see there is a difference between people with knee osteoarthritis and hip osteoarthritis, in that more people with knee osteoarthritis are overweight. So here you would have people who have normal weight, which is about 25%. So 75% are either overweight or obese when the knee is their main complaint. But for people with hip is the main complaint, nearly 40% are normal weight and 60% are overweight or obese. And you can see the proportion being obese is smaller for the hip than for the knee. And this is quite typical. And we can see that in risk factors for these diseases. And it is, some would say that it is different diseases, at least the joints look very differently. And the loading of the joint is very different. We can also see that people with knee osteoarthritis typically have had they've had their symptoms for a longer time than patients with hip osteoarthritis. So what are then the results after GLAD? Well, I'm showing 4 outcomes for you: pain, use of medication, walking speed, and quality of life. And this is immediately after GLAD. So this is like around about 3 months since you started the program, because you will have the patient education. Usually that will be once a week for 2 weeks. And then you have the treatment program for 6 weeks. What we can see is that on average, there is a decrease of about 25% in pain for patients with knee and hip osteoarthritis. It's 27% for knee and 23% for hip. Interestingly, we can see that 1 out of 3 actually stop taking painkillers following this program. And that goes both for paracetamol, for NSAIDs, and for opioids. So that is very good. And if we can see that the amount of medication they take is reduced with about 25 to 30%, which is really good. We can also see that these patients walk about 10% quicker. And that comes in very handy when you, for example, are crossing a very busy street, that you can get over and be safer than before. And we also see there is about a 10% improvement in quality of life. So this is immediately after the program. We can see reduced pain and intake of painkillers, improved physical function, and quality of life. It should be noted that we have a very high compliance in GLAD. So actually 8 out of 10 patients, they attended both educational sessions, and 8 out of 10 participated in at least 10 group-based exercise sessions. And this is a big problem in many places, that patients don't want to take the medicine or don't take enough of the medicine. But I think we have been successful in that. And I do think that patient education is part of that, because patients learn about why it is important, what they can do themselves, and the responsibility that they have to take for their treatment themselves. And they also learn about the fact that exercise is not harmful to your cartilage and that it will not damage your joints. But the interesting part, I think, as a clinician and as a researcher, is that the results, they are actually maintained at 1 year after GLAD. So when we follow up these patients at 1 year, we can see that there is actually a larger decrease in pain. So the improvement has continued and is actually a little bit larger than it was immediately after this program. This is very unique because in many randomized controlled trials where there was an improvement immediately after the program, after 1 year, these people have often not maintained their good results, but they are maintained in GLAD. And we can see that all over the world, not only in Denmark, and I'll come back to that. We can see that the improvements in quality of life are even larger. And from a societal point of view, it is important to see that the number of days on sick leave is actually smaller during the year following GLAD than what it was the year prior to GLAD. It is, of course, also important to remember that GLAD is not a randomized controlled trial, so there is no control group. So we can't really, from a scientific point of view, say that these changes we see are due to the program, but it seems quite likely. So at 1 year, we can see reduced pain, higher quality of life, and fewer sick leaves. Sick leave is important for many reasons because it's very costly. And we can see that at least in the Western countries, musculoskeletal diseases, and osteoarthritis is by far the largest group here, are responsible for maybe 2 to 3% of the gross domestic product. And that is more than cancer and diabetes and cardiovascular disease. So these are really costly diseases. And what is costly is actually, the treatment is costly, but what is much more costly is the indirect cost that is for sick leave and early retirement and pension. So it's really important that we can change that parameter. So because we have been able to show these good results in Denmark, GLAD is now a success not only in Denmark, but actually across 4 continents. So the first country to take up GLAD outside Denmark was Canada. So we have been collaborating with the Canadians in 2015, and they now run their own program and have their own courses. And they have certified more than 700 clinicians all over Canada, and they have collected data, and this number is even higher now, but it's over 4,000 patients now, nearly 5,000 patients. The next country to take on was Australia, another large country. And they have trained about the same amount of clinicians, and they have data from about more than 3,000 patients as we speak. And GLAD is also available in China. But in China, there are physiotherapists. There are no physiotherapists working with people with osteoarthritis in the healthcare system. So in China, the program is actually run by orthopedic surgeons and nurses. And here I am visiting China on one of many occasions, together with the orthopedic surgeons and the nurses and the patients participating in this program. The infrastructure is not in place in China. Since there are no physios working in this area, there are of course then fewer clinics, and there are no exercise rooms. So they have had to start to build exercise rooms and to change the reimbursement system so that patients can get access to this treatment, and that takes time. So they are a little bit lagging behind when it comes to giving courses and certifying new clinicians and having data entered into their registry, but they are well on their way now. And GLAD started in Switzerland in 2019. And we can see that there are improvements not only in Denmark, but actually also in all the countries. So what you can see here are the percentage improvement for pain, walking, sit-to-standing, quality of life in Denmark. And the orange is Canada. And you can see it's similar or maybe even larger. And the same for Australia with similar or even larger improvements. And these are not yet published data, so I don't want you to tweet them or so. And GLAD has also been exported to New Zealand. But unfortunately, that was just before COVID hit the world, so they have not really started yet. And this month, we have taught the first course in Austria, and we've done that online. And we have also taught the first course in the Netherlands. Also online. We are adapting to the new world. So there are some learnings along the way, and we have busted some myths. One was that we were told that, yes, it's a really good idea to do this exercise, but people want quick fixes. They don't want to spend all the effort that is needed to do exercise. But I would say that is wrong, because many people actually want to treat their osteoarthritis with patient education and supervised exercise therapy. And as of now, there are actually 50,000 patients in Denmark who have, at least in part, paid for the program themselves and enter data into the registry. So we know this. There are a lot of people who would like to spend the time needed to treat their osteoarthritis with exercise. We were also told that clinicians want to do their thing. They don't want a standardized program. And I would like to say that GLAD is standardized, yes, because you deliver a minimum treatment, which is the patient education and the exercise. But the exercise program is adapted to the individual. It is progressed according to how the individual improve. And as a clinician, you're also free to add on other treatments that you find beneficial. So yes, it is standardized, but there is also a lot of flexibility. And we have actually learned that it is possible to empower clinicians to, with confidence, deliver care according to clinical guidelines for osteoarthritis. And we have trained more than 1,000 in Denmark, and together with the other countries, as you've seen, we have trained many thousands of clinicians by now. Another aspect that has proven very important in Denmark is the trust from general practitioners, because at least in Denmark, general practitioners did not feel that comfortable with writing a referral for physiotherapy, because they were not convinced that it works, because they didn't know what it was. What is physiotherapy? To me, physiotherapy is not a treatment. Physiotherapy is a profession. And it is a profession that can deliver very different treatments. Physiotherapists can deliver active treatment like exercise therapy for people with osteoarthritis, and we know that is effective and it is according to clinical guidelines. Physiotherapists can also deliver passive treatments. That is heat, cold, ultrasound, other types of machines and whatever devices you may have. They are not effective they are no more effective than placebo. That is not good, and that is not evidence-based to deliver that type of treatment. And this is the reason why general practitioners in Denmark did not feel comfortable in referring to physiotherapy, because they did not know if their patients were going to get evidence-based active treatment or passive treatment with some kind of machine that is not evidence-based. So for GPs, they very much prefer to refer to GLAD because they know the content of the program and they know the results. So then we have the question, does exercise really work? Because that is something that it seems very paradoxical that exercise should relieve your pain. Many patients would think the opposite. So data is really key to show that exercise works. And I have already shown you the data, so you know we can show that it works. And in Denmark, this has really helped change the reimbursement system for physiotherapists in one of the 5 healthcare regions. So these days, the physios, they are reimbursed to deliver patient education. That was not the case before GLAD started. They're also reimbursed to enter data into the registry. That did not happen before. And they are reimbursed to deliver exercise therapy in a group-based fashion. So all these changes to the reimbursement system has happened. And I would say, and that's the feedback we've got from the healthcare authorities, that the data we have collected and the annual report that they have gotten has been very eye-opening for them, because they can see that what physiotherapists do actually works. So in summary, the GLAD is a feasible concept in clinical practice, and the data from the first 5 years of enrollment demonstrate pain reduction and improved physical function and quality of life. And we can see that these improvements persist 9 months after the intervention ends. We can see that teaching the content of clinical guidelines to clinicians and providing a free of charge registry for data collection, that has increased the quality of care provided for patients with knee and hip OA in Denmark. And it can be successfully adapted and implemented into other countries with different healthcare systems. So in 2019, GLAD was nominated for the Value-Based Healthcare Prize. And this year there were more than 175 applicants from all over the world, and 13 were nominated for the prize. And as you can see on the list, it was very influential and sexy diseases like cancer and stroke and all kinds of things. And also a treatment program for people with osteoarthritis, and that was GLAD. We were very surprised, and we were so happy that we were nominated, because usually there is very little attention to osteoarthritis and to patients with osteoarthritis if you compare to heart disease, diabetes, cancer, and for good reason. There should be a lot of focus on these diseases, but I believe there should be focus on people with osteoarthritis as well, for good reasons. So we were really happy we were nominated, and that was like a victory to us. But we actually won the whole thing. So we won the Value-Based Healthcare Prize in 2019. So we can say that GLAD is really value-based healthcare. And that has meant a lot to us. And I would like to thank you from myself and from the whole Danish GLAD team. To the far left, you see Professor Søren Skov, And then you see Sarah Kroman, who is our expert clinician. She only works with GLAD in her clinic. And then we have Lustig Möller, who helps us with the business part, and Dode, who is our database manager, and Mette, who also has helped in being in contact with clinicians and responding to questions. So thank you very much for listening, and questions, please.
All right, thank you, Professor Rose. That was so awesome presentation. I believe some of us are really interesting to discuss with you. Okay, we'll go ahead. There's some question here. I will read it. Okay, the first question from Muhammad Nutrianto. Professor, what is the difference between GLAD exercise and other exercise for knee osteoarthritis condition?
Okay, so I would say that the difference is that the goal of these exercises is to improve the trust in the hip and the knee joint. And they are neuromuscular in the sense that they aim at improving also the function and to give pain relief to the joint. And the focus is on the joint. So it's actually the joint's condition that drives progression or regression. You know, if you did aerobic exercise, it would be your heart rate that would help you determine if you should increase the resistance or not. If you did strength training, it would be how many kilos you can lift that would help you determine if you should progress the exercises or not. Does that respond?
Yes, it is.
Your question?
Okay, the second question is from Devi. Why GLAD use Nemex and no other exercise, and how long the treatment is?
So we do 6 weeks, which is 12 sessions. And the reason we do that is because in systematic reviews, it has been shown that the pain relieving effect from 12 sessions of exercise is about twice as large as it would be from fewer than 12 sessions. But of course, more would be better. So it would be even better if you had more sessions, but this is what we could get into clinical guidance. Sorry, I have a dog here.
Right.
It's a puppy dog. So that's why we do 12 sessions.
12 sessions, okay. 12 sessions for how long, Prof? 2 months, 3 months?
Can you please repeat the question?
12 sessions for how many months? 2 or 3 or 4?
No, so we do, sorry.
Maybe he wants to join us.
Oh, well, she can hear there is a big car outside.
Oh, okay.
Park on that car. So we do 2 sessions a week for 6 weeks.
All right, for 6 weeks. Okay, the next question is, okay, there's some person who really interesting. They want to, how to make GLAD in Indonesia? Is it possible? Is there any procedure we should fulfill or do? Professor?
Well, I don't know if GLAD is possible in Indonesia because I don't know enough about your healthcare system.
All right.
But we have had requests from some other countries like Sri Lanka and Vietnam and other countries. And there we have realized that there are some difficulties in your countries because maybe because of culture and maybe because there has been there is not the same acceptance for exercises treatment as there is increasingly in Scandinavia and in the Western countries. But you know much more about this than I do.
Yeah.
So I think that would be up to a discussion to see if that is possible.
All right. So if it's possible, in our opinion, is it possible? Is there any procedure to do that?
Yes, it's a long procedure. It's much longer than I can talk about here, but
Okay.
there is a full procedure for doing
All
that. Yes.
right. Okay. Okay, everyone, is there? Look, I think we cover all of questions. Maybe if anyone want to ask again, we still have time. There's a question more. Why electrotherapy is no better than placebo?
Can you please repeat it? Why is not?
Why electrotherapy is no better than placebo?
Well, I can't say why, but I can say that the studies that have been done have shown that electrotherapy is no better than giving a sham treatment.
Oh, all right.
And that goes for a lot of treatments. I would say it goes for acupuncture, it goes for TENS, it goes for ultrasound, it goes for a lot of these machine-driven treatments, that there is an effect, but you have exactly the same effect if you don't turn on the machine. But you have the blinking and lights and whatever you have, so the patient believe that they get the treatment. So I would say that it is largely driven by patients' expectations, the placebo effect.
All right.
And we can see that the placebo effect is actually larger for more invasive treatments. So it's largest from surgery. It's a little bit smaller from injections. And again, it's a little bit smaller for pharmacological treatment with pills, which is about or a little bit the same as what we can see from electrotherapy and acupuncture, etc., from machines or devices.
Okay, cool. And then we have another questions from Firman. What are the education contents we should deliver for people with osteoarthritis?
I'm sorry, I hear you poorly. Can you repeat the question? What
Okay.
are the
what are the education contents we should deliver for people with osteoarthritis?
So if you're asking, just to repeat, if you're asking what are the one-liners that you should give your patients,
Yes.
One thing I would like to say that I think is really important is that osteoarthritis is a disease that can be treated. It's not something that you necessarily get because you get older, and it can be treated. I think that is something that we need to tell our patients, because a lot of these patients, they have heard that, well, there's nothing we can do about it. You just have to learn to live with it. And even worse, they may have heard that they should just rest and sit still, which is the absolutely worst they can do. So I think that there are some messages that definitely needs to be changed to these people. They should learn that physical activity is good, not only for their osteoarthritis, but also for their general health. But they need help to get the right type and the right amount of exercise, because it is difficult to start. And many may have gotten osteoarthritis because they've had a hard job. They have been working with kneeling, squatting, bending, knee bending jobs for many hours and many years. That is one of the reasons why I get osteoarthritis. You can also get osteoarthritis because you've had a knee injury, because your mother or father gave you the genetic component of osteoarthritis. You cannot actually get osteoarthritis because your muscles are too weak or because you have been too physically inactive. So it's not easy. You should do moderate physical activity, not too much, not too little.
All right. Yeah, not too much, not too little. Okay, is there any cure for osteoarthritis? Because some people said that the exercise can make the cartilage grow.
Well, what I would like to say is that we use exercise to manage the symptoms of osteoarthritis. We use it to manage the pain and to manage the functional limitations. And then I think your question is if exercise can change the cartilage, if it can improve the cartilage.
Yes.
So what we can say about that is that cartilage largely consists of two components. That would be proteoglycans and collagens. Proteoglycans are negatively charged and they attract water. And they are responsible for the shock absorbing capacity of the cartilage. And we have shown in studies that with neuromuscular exercise, as we do in GLAD, we can improve the number of proteoglycans in the cartilage in people at risk of osteoarthritis. So it seems like when we do exercise, we can, the way we do with a physiotherapist, we can improve the quality of the cartilage. But when the collagen is, when you have a collagen loss, when you have lost volume of cartilage, that cannot be restored. But I think it is important for you to know that if we would take x-rays of people in Indonesia in the population, and we would ask them about how much pain they have, I'm very sure that we would find the same thing as we have found in Sweden and Denmark and the United States and all over the world, which is that the correlation between symptoms and what we can see on radiographs is very, very poor. It's actually like tossing a coin. So the way that we are thinking about imaging finding these days, that is not to diagnose the disease. It's more that that's a risk factor to develop the pain, because it is the pain and the functional limitations that are important, because that is what drives the patients to seek medical care. And that is what drives their sick leave. It's not what you can see on an X-ray or on an MRI. That's a major change that has happened during the last 10 years, maybe, that we have gotten much more knowledgeable about that. And actually in Europe, the guidelines from the rheumatology, European Rheumatology Association, they recommend against using radiographs to diagnose osteoarthritis. And that is the same in Sweden and in Denmark, that in the clinical guidelines, it is advised not to use radiographs to diagnose osteoarthritis. So the diagnosis should be a clinical diagnosis where you do a clinical exam, you look for symptoms and you look for risk factors.
All right, that's actually same condition in here. Some patient need to X-ray first, and then they got diagnosed and with osteoarthritis. And
Yes.
we hope in the next time maybe we will do like in Europe country.
Yes, and it's been like this in Europe for a long time as well, and it still happens to a large degree that a lot of people will have an X-ray, but it is shifting. Mm-hmm. Because the thing is that it can take, osteoarthritis develops very slowly, so it can take maybe 10 years from the onset of the disease until you have radiographic changes. And if you wait until you have radiographic changes, you have lost 10 years where you could have treated the patient early to avoid progressing the disease and progressing the symptoms.
Okay, that's really awesome. Okay, I think that's all. We all cover all the questions, and
yes.
So it's time to end our webinar. But before that, is there any message for Indonesian physiotherapists, professors?
Yes, I would say that you should acknowledge how important it is that you treat people with osteoarthritis. They really need you, and you can make a huge difference for a lot of people in Indonesia if you use your knowledge to treat these people. And please make sure that you teach them about osteoarthritis. They don't have to be worried, and that they should start to be physically active. But you need to hold their hand because they may be anxious and worried, and they need your support in getting going.
Okay, great. Thank you very much. It's such an honor to have you here in our webinar, and we hope someday we will have you again, if you don't mind.
I really would like to come. I'm looking forward to the day we travel again.
All right. Thank you, Professor Roos. Tack ska du hej. Is that how I supposed to say that?
That's really good.
All right.
I wish I could say the same in Indonesia, but it's been a pleasure. And I wish you a good evening.
Good evening.
Bye-bye.
Take care. Bye-bye. Okay, everyone. So we appreciate you being here. We'll see you in another webinar of Physio Kita. Don't forget to join and follow our social media, and you will get many info, many journal, many articles about physiotherapists. And we'll see you in the next time. Bye-bye. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Udahan.
Udah, Matt.
Udah ya, Mbak ya.
Siap, Mbak.
Okay.
Dadah semuanya.
Ya, terima kasih. Waalaikumsalam.
Waalaikumsalam.
Mau apa ya?